Thank you. Good afternoon. We got some heavy hitters for you today. I'm a Braves fan. I wish we had them a little earlier in the year. But we have them here today. Hopefully you enjoyed the day. And today what we're going to have is we want to welcome you to the discussion on the demand-driven delivery system, which basically we're going to talk about the patient-centered medical home today. So thank you for coming. We've told you all those who need CME credits, please come up and sign at the end of the presentation. So thank you, and let's get started. I would like to welcome our panel of thought leaders and thank them for being here today. Our panel includes Mr. Richard Gittimer, Chief Quality Officer at Emory. We have Dr. Wayne Hoffman, Healthcare Consultant. We have Dr. Peter Youngboot. He's the Senior Vice President and Medical Officer at WellStar. And then, of course, Mr. Bruce Trimble, Administrator, Albany Internal Medicine. Let's give him a big hand and thank him for being here today. Shortly, they'll give you a little more information about themselves, their organization, and an opening statement. But today what we want to do is we want to make sure that we have a lively discussion. We want to get you involved, give you a brief overview of patient-centered medical home, and then I'll ask the panelists to give that brief introductions and opening statement. We'll go into some questions, but we want to get you involved earlier in this presentation. What we're going to do is we're going to ask you, what are your questions and comments that you'd like to bring to the panelists so we can have a lively, valuable discussion for you, the audience. So let's begin. How many of you are clear on the definition of a patient-centered medical home? Well, you see, we didn't raise our hands either. So hopefully we can help you today. So let me just give you a little overview of the patient-centered medical home. This is a model which is based on a strong primary care system that's patient-centered and allows greater access to our population to improve the quality of health and hopefully across the nation. Have you heard of AHRQ, which is Agency for Health Research and Quality? This is the accrediting body, and if you work with any medical practices, healthcare organizations, this is the body that does the accreditation for patient-centered medical home. This is part of their definition and description of a patient-centered medical home. The medical home model holds promise as a way to improve healthcare in America by transforming how primary care is organized and delivered, not simply as a place, as a model that delivers not simply as a place, but as a model that delivers the core functions of primary health care. AHRQ recognizes the central role of health information technology in building a primary care delivery platform that the nation can rely on for accessible, affordable, and high-quality health care requiring workforce development and fundamental payment reform. So we'll discuss some of this today. There are 5 functions which are attributes of the patient-centered medical home, and then we'll move into the discussion. Number 1, it has to have comprehensive care for the patient. It meets the patient's physical and mental health care needs, including prevention and wellness. And also, it has to have a team approach involving the team of nurses, pharmacists, social workers, nutritionists, care coordinators, etc. Number 2, it must be patient-centered, relationship-based with the orientation toward the whole patient, partnering with the patient and the family, recognizing that the patients and the family are the core of the healthcare team. Number 3, it must provide coordinated care, care across all elements of the healthcare system. Number 4, accessible care, which means shorter waiting time. The patient has access to the provider, emails, personal health records, etc. And number 5, quality and safety. A commitment to quality improvement, decision support tools, responding to patient experiences and patient satisfaction, and then sharing robust quality and safety data and improvement activities. And if you heard Reed today, I'm sure most of you did, he talked about a number of these things which are important to the coordination of care within our health system. So what we'd like to do is move straight to the panel have them to introduce themselves, the organization, to give you an opening statement, and then we'll kind of move into the discussion. Thank you, and Rick can start.
Good afternoon. My name is Rick Gittimer. I'm the President and Chief Quality Officer of Emory Healthcare's Clinically Integrated Network. It's called the Emory Healthcare Network. I'm a general internist by training and still practice and still actually saw patients this morning. As we start to put our network together and figure how we're going to be successful as an integrated network, sort of the coordination of care, the oversight of care, the oversight of all the complexities in healthcare really fall very much, at least in our minds, to primary care. The problem is primary care really can't take that on with the current model of care, and that's why these innovative approaches or newer approaches, such as the medical home, we'll get into details later, are really the kind of things that really we look towards to really move us forward to be successful with our networks and to meet the needs of our patients.
Good afternoon, I'm Wayne Hoffman. I'm a family doc by trade. I've done a wide variety of things, I guess. Was a country doctor in the mountains of North Carolina in a town of 500 people. Been doing OB for a while, and then moved to Atlanta, where I had a suburban practice out in Stone Mountain. And some of my colleagues, I guess, would say I crossed over to the dark side and started to do medical administration and worked for a variety of health plans, most recently WellPoint, where I had responsibility for their disease management and wellness stuff nationally, and also national account medical management. Then I left there and started my own consulting practice, and now I am also functioning as the president-elect for the Georgia Academy of Family Physicians. And our academy has been kind of the leader, at least among primary care groups, in terms of advancing this new model of patient-centered medical home care. It's really, not only do I believe that it is going to help save our healthcare budget in this country, I also think it's also going to help save the specialty of family medicine, because it really does put primary care physicians into the forefront of managing comprehensive care for the whole patient. And I have to admit that when I was working in the health plan sector, I actually thought we already had this kind of thing. And one of the reasons I'm so thrilled to be here with you folks is that this model won't work without robust IT behind it. So I think it's very important that we're talking about this here. So thank you for having me.
I'm Bruce Trickle, administrator at Albany Internal Medicine. We're an internal medicine and family practice group, private practice. It's physician-owned. We have 10 physicians, 3 mid-levels, and a staff of 78. We're all ambulatory, and back in, I guess it was late 11, early 2012, we, as part of our strategic planning, had an idea that we weren't going to survive the business of medicine in the coming years if we didn't make some changes. And so we planned for some of the new models. We approached the ACO model and actually started an ACO with 3 other practices in town, and started that 1st January. We partnered with the Georgia Academy Family Practice towards PCMH. We're about 2 weeks away from submitting our final application, so we're kind of in the home stretch. We haven't leveraged technology as much as we should. That is our next, I guess, hotspot that we need to approach. We've been busy trying to get through the application process for PCMH accreditation and ramping up our ACO operations. So it was important to me to come to this meeting, and I've enjoyed interacting with many of you. Thank you.
My name is Dr. Peter Youngblood, and I am the Senior Vice President and Medical Director with the Wellstar Medical Group. And I'm sure for those, my background is internal medicine, and I came down from New Jersey in January, where I had been the Vice President of Medical Affairs for an independent hospital for about 9 years, and then was also back in practice for about a year and a half before coming down. For those of you who are from the area, I'm sure you've heard of Wellstar. The Wellstar Medical Group is part of the Wellstar Health System. The system, from a hospital point of view, is comprised of about 5 hospitals. Our flagship is in downtown Marietta, the Kennestone Hospital, which is a 600-bed tertiary hospital. The medical group is approaching 700 providers. About 2/3 of those are physicians, and 1/3 are what we call mid-level or advanced practitioners, such as nurse practitioners, physician assistants, and midwives, and audiologists, and other professionals. We've embraced the patient-centered medical home model because we believe it's the right thing to do for patients. We also recognize that primary care is the foundation for care, and it's how care gets coordinated. And we also know that there are fewer and fewer physicians coming out of programs today who are interested in primary care. So we have to find new ways of delivering that care. And we also think that it's a part of our strategy around accountable care organizations. As Bruce mentioned, we are also an ACO. In fact, Wellstar was the first accountable care organization in Georgia. And we see the medical home as an integral part of our accountable care focus, which is on really bending the cost curve while providing the highest quality for patients.
Thank you all. Let's go ahead and start with questions for the panel. First question, how will the patient-centered medical home model help improve quality within healthcare practices and organizations? And you can actually comment how you see it improving within your quality within your organizations.
I mean, I'll start with that. I think the way that it improves quality is primarily by involving patients in their care. Everyone obviously cares about how well they're doing, but this is a way of improving communication for patients, improving access, making sure patients can either come into the office to see their physician or healthcare provider when they need to, or be able to reach them outside of traditional office hours through some means, either telephonic or electronic. We have installed a pretty powerful electronic health record. When I say so, we're in the process of implementing this electronic health record, and one of the nice features about it is that it has a patient portal. And what that means is that just like we're all used to with our bank accounts, logging into our, see our information and check our balances or whatever you might do online for so many other aspects of your life, this patient portal allows you to do the same for your healthcare. So if you have labs drawn or some other imaging or testing done, you can go in the next day or the day after when those results are available, and you can check those. We've set the system up such that those are immediately released out to patient portals, and there's no delay there. So this is a way, again, of really involving patients in their care. That's what we see how powerful a medical home is.
I think in our private practice, where it's made a difference is, it's forced us to take a really detailed look at our workflow and our processes and how we take care of patients, how we interact with them and their families, how we handle transitions of care, and I think that's improved the quality. We were somewhat naive to think that we were providing a very high level of care, and only to find that there's always room for improvement.
I would agree with that. I think, to echo Bruce and Peter's comments, I think this changes the way we deliver medical care in this country. It changes it from a reactive state to a much more of a proactive state. I mean, when I was seeing patients actively, I couldn't tell you how many diabetic patients I had. I could not tell you, certainly couldn't tell you how well controlled they were. And so what this does is having the data behind it where you can actually have a disease registry and look and see how your patient population is actually doing, truly manage a population proactively, not just reactively, more of a wellness care rather than sick care that really is going to help reduce costs and improve quality. It changes a physician's practice focus from one of just trying to see as many patients as I possibly can to one of true quality improvement. And one of the things Dr. Tuxson said a little while ago was disruptive innovation. This truly is disruptive innovation in my mind, because this is, you're allowing people to practice at the top level of their license. So that nurse practitioner can see plenty of patients that I thought I used to have to be the ones to see. My nurse educator can educate them probably a lot better than I could in terms of how to manage their diabetes. So allowing people to do the top of what they are trained to do really will help improve the way we deliver care.
So going forward, it's always hard for something like this. I would say ditto. Plus, just a couple of sort of filling in some of the gaps a little bit. I think that if you really sit down and you look at the medical literature or just look at the national guidelines, There's an organization, United States Preventive Services Task Force, that actually publishes guidelines that primary care docs ought to do for most patients. You just add up all the things that the United States Preventive Services Task Force says that we need to do. We have about 15 minutes left in the day to actually take care of anything else that the patient cares about. So medicine is far beyond, we heard earlier this afternoon, far beyond Marcus Welby for anybody here who knows who that is. It is really a team sport, and the medical home really very intentionally engages the entire healthcare team to the top of their license, but also forces you to create processes so that everybody can be on the same page, as opposed to historically, and frankly the way I practiced when I left training, it's, the only person who really knew what was going to happen next was me. And now to do this as sort of as a team-based approach, not only can I get other people to help me in a proactive way, but also I can measure my performance there, identify those places where I missed what I intended to do. Because now everybody knows what that is, and we can measure it, and we can close those gaps in care, and we can also measure our overall performance, and in the spirit of quality improvement, identify those places where we can do better.
Thank you. Great comments. And as some of you know, and some of you may not, the Affordable Care Act basically encourages the patient-centered medical home model, especially for those who have chronic diseases. So it's actually a model it's coming all across the country. Let's kind of turn it just a little. With the patient-centered medical home, there is a cost to the practices and, of course, the health systems that you guys probably are well aware of. How does this model, can you talk about the costs that could be incurred by practices? But also, how does this model help with the financial success and the business operation of smaller practices and healthcare systems and hospitals? That's my wife calling. Anybody who's
I'll just sort of start. I mean, I think that, first of all, understand, as we heard earlier this afternoon, fee-for-service is going away, but we're still in fee-for-service. And so everybody's on the treadmill running fee-for-service. So there's a measurement of work in our world called RVUs, resource-based relative value. And unless you're generating RVUs right now, it's costing you money. Everything I just talked about, we've talked about as far as looking at registries, proactively reaching out to patients, reviewing data to do quality improvement, to identify those gaps in care and reaching out to close those gaps in care, all of those take away from RVUs. So until the payment model changes, it's going to be very difficult for a practice to transform. But once it does, it now starts to value what we as generalists do. And that is oversee and coordinate care. And now we create an enormous value to the system, and we can actually, as the payment models change, whether that be as pay for performance or shared savings or full risk, as those models change, now this non-RVU based work does actually create value for the practice and creates revenue for the practice. But I really think until the payment models change, it's a really hard sell unless the organization is just going to fund it at all.
And I'll add to that too, Rick. What we found is that even without changing payment models, because of the increased efficiency in a practice, you will generate more revenue in your primary care practice especially. Often not enough to cover the change that you have to make. It costs approximately what we found at the Academy was between $50,000 and $70,000 per practice to make this transformation. That does not include the purchase of electronic medical record. That's on top of that. So one of the reasons we only had 4 practices in Georgia that were patient-centered medical homes in 2010 was because it just cost too much. Physicians could not afford that kind of cash outlay unless they were possibly part of a large system. So we only had 4. So the Georgia Academy of Family Physicians decided to create a patient-centered medical home university. And we've taken almost $500,000 out of our long-term reserves to set this up so that we could provide it to the 3 to 5 doctor practice for several $1,000s instead of $70,000. And that's why we now have almost 70 practices, more than 70 practices, that are now patient-centered medical homes. And what they're finding is tremendous increase in revenue, tremendous increase in productivity and efficiency, and obviously higher quality care. So once we get the payment reform through, I think we'll find a real rush of practices that are willing to make this change, but it costs a lot.
And I have to say that even though we were partnered with Georgia Academy, my estimation is that it was between 80 and 90,000 out of our budget to actually pursue this endeavor. You know, in hindsight, you know, it definitely was worth doing, but it takes a huge commitment, and it takes a lot of what I call physician buy-in to move it forward. And that was one of the more difficult pieces. You know, we had some physicians who were comfortable in their practice style and environment, and others that were looking to think, you know, to the future. And but you know, I think just in a recent release by Blue Cross as an example, you know, there's a patient-centered medical home for primary care that they're releasing effective 1 January. It's going to be significant income for us on a per member per month type basis, with a chance of shared savings at some future date. And so that's the payback we're seeing, and we're enthused about that, and hope that other carriers pursue the same.
We're also hopeful that some of the payers will come forth with these per member per month, what we call PMPM fees to cover the cost of medical home. There are certain parts of the country, certain states, where the payers have been more forthcoming than what we've experienced here, but we continue to be hopeful that it is an expensive endeavor, because as people work up to their highest level of licensure, it leaves certain tasks undone. And what we have found, we have had to introduce new staffing as much as we've tried to do it in a lean way and without increased staffing. I think where it benefits practices on the financial side is by improving efficiency, by clarifying staff roles and what they do, and also by driving new patient volumes through higher patient satisfaction, better word of mouth about a particular practice or a team of providers at a location. There is a little bit of a hidden cost, though, because, as I mentioned earlier, much more of the communication now can happen without the patient arriving in the office. And, you know, obviously that patient visit is what triggers the charge to be billed, that drives the revenue. As those visits drop because more communication is happening through electronic means and otherwise, that volume falls off a little bit. So that's a hidden cost that, you know, we've kept an eye on. Again, we know it's the right thing to do. We know it's what patients want as consumers. They want that convenience, so we are moving in that direction.
Thank you, thank you. I think we've addressed one of the major barriers to the patient-centered medical home already around cost. Medical practices have already seen costs rise 28% since 2008 around information technology within their practices. So cost is a barrier, but information technology, health information technology is much needed as part of a patient-centered medical home model. A lot of people don't know. You actually could probably be a patient-centered medical home without HIT, but Dr. Morrow, when you say that's pretty hard, right? So can you all address the importance of HIT, even though you had that cost, what would be the advantages and why it is central or the cornerstone, what we say, of the patient-centered medical home?
I think it's the issue of engagement of the patient and their caregivers and the family with our team. Without technology, you can't promote that, and you can't make that part of your workflow and your, you know, the efficiency of it. That's why it's extremely important.
I would add that I think the importance of technology is really data, but also information out of that data. And something that marries your financial data with your clinical data, real time, not just claims data. Now, I can say that I'm not working for the insurance company anymore. But it's like claims data at best is old. It's 90 days old at best. So the closer you can get to marrying that in real time with your clinical information, that's when you're really going to be able to manage your population and keep them out of the hospital and keep them out of the emergency room.
I mean, you can do population management of a condition or two on paper, and I've done that. But when you start to consider that patients don't just have one or two conditions, they have diabetes and they have heart disease and they have congestive heart failure and they have and they may have depression, and there may even be asthma or chronic lung disease there. It far exceeds your ability to manage that on paper. And so you need health IT. And just to give you an idea, and maybe this is obvious to you, maybe it's not, it's the kind of thing that I know a diabetic needs an eye exam, a foot exam, their LDL check, their hemoglobin A1C check, which assesses their control. They need their urine check, and there's one more that I forgot at the moment. But they need those 6 things, right? I know that. There's no diabetic in my practice that doesn't need those 6 things. But then there's also the patient with heart failure who needs to be on a beta blocker, and maybe they have coronary disease and they need to be on an aspirin, they need to be on an ACE inhibitor. So there's the 4 or 5 things there. And the same kind of thing with depression. We need to make sure they have the appropriate follow-up. You need to make sure that they're on the right agents. So you put all of that together, and it far exceeds your ability to sort of manage that as a human. And so we need IT to basically take all that stuff and basically say, number one, so-and-so's coming in today, what isn't happening for them? And ideally, my team takes care of all that, and I can just focus on what bothers them today. And then we also need the ability to say, hey, here are processes for how we care for all these patients. What's our overall performance? Oh, we have an opportunity here. Patients with heart failure aren't getting, aren't all on the beta blockers, and maybe the patients with diabetes aren't getting the A1Cs as frequently as they should get. And then you can do quality improvement around that. All of that becomes very difficult without health IT. Data source is huge. Data source is enormously huge. Just having an EMR doesn't mean you have the data sources you need, because you have to capture that data in an analyzable fashion, or whether that's in a discrete form or whether that's with natural language processing or some other new technologies is a whole other discussion. But health IT is an essential enabler of population.
I would add that the value of IT is that it saves time, both for the patient as well as the physician or provider, and it allows for more decision-making or better decision-making. And when we think about the medical home, some of the basic tenets of medical home, we tend to think of medical home as thinking about the patient when they're not in the office. So what that means is that we plan for the patient to visit. So we look through the list of patients who might be coming in tomorrow, who might be coming in next week, and we identify what their needs might be. And then the other piece of medical home is tracking the patient once they leave the office. So if you send them for a test, if you send them for a referral, you need to track, make sure that happened, and bring that information back into the record. So the information technology allows you to have a lot of information about the patient at your fingertips, and again, plan for the visit. It allows the patients, because they can look at their own information, to think about what questions they might want to ask their physician or provider, to maybe bring in information that's not captured in the record so that we can enter it into the record. The other thing that's part of the medical home is reconciling medications. So, for particularly patients who are on multiple medications, it's critical that we know which ones they're on. And technology can tell us if there are potential interactions, keep track of allergies or adverse reactions to medications. So, the ability to make better decisions faster, I think, is really the power behind information technology. And as I mentioned before, there's an element of transparency that makes for better systems, in any better situation, any system. And I talked about how patients can access their own medical record and information. That kind of lifts that veil that was always hiding information that was sort of in the paper chart. You weren't ever quite sure. There was that scene in Seinfeld, for those of you who remember, when Elaine goes into the doctor's office and she wants to know what the record says. Well, that joke would no longer be funny, because that's not today's reality.
Thank you. Wayne, I'm a family physician too, and I'm confused, really. PQRS, meaning for use, patient-centered medical home, accountable care organizations, practices, smaller practices, larger practices, everybody's kind of confused about all this stuff. Can you guys help me out? How does all this relate? How will it improve? Will it improve quality? Will all this come together? Can you guys help me out?
I think initially it's to track quality. Just meaningful use in PQRS in particular I know when we initially attested for meaningful use, it seemed like all we were doing was checking boxes and filling squares and making sure we did something in a patient visit. We weren't actually taking care of the patient. With technology, we've been able to leverage that so that the physician or clinical person is actually able to give the care to the patient. And so I think we're moving in the right direction, but I think initially it detracted from providing quality care.
And it's that argument of process measures versus outcome measures. So much of this alphabet soup we talk about are really process measures. Check the box, did you do it? Not so much how does the patient doing? What's the outcome of that care? So I think we're making progress. And they're trying to actually combine some of them. The NCQA recognition program for patients at medical home is based on meaningful use criteria. So it's not in addition to, we incorporate that. But your point is well taken.
It's all mingled.
So, a couple of things. I think that meaningful use is intended to be an enabler, and that we need an IT infrastructure. And I'm confident that there are a lot of organizations without the meaningful use dollars that would not have become electronic. The project with Georgia High Tech and all of those kind of things wouldn't have happened without the federal subsidies. And with getting these practices electronic. So while there's a lot of it that is checking the box, it's just sort of that pain you got to go through because we have to transform healthcare from an electronic perspective. PQRS, the spirit of it was a good thing. I'm a strong believer in transparency. And even though transparency, can be unfair sometimes because people don't have, because all of these measurement systems are so nuanced, for people to make actually decisions based on that, it's very difficult. But what transparency, what these measurement systems do, which now makes data available to be transparent, is it starts to focus effort. And if you look at, acute heart attack care for patients in hospitals, if you look at basic stuff like are they on the medications they're supposed to be on, the performance of that as far as the percentage of patients who got all the care that they're supposed to get has gone up dramatically. That is absolutely because of core measures in the hospitals. And so I think it focuses effort. The problem is people then take that information, independent organizations then take that information, do some proprietary manipulation of that, and then use it to try to discriminate between a good healthcare system and a bad healthcare system, a good doc and a bad doc. And that's the part that's painful about all of this. The other thing that it does do is it forces a lot of work to just capture the data, and I think that's where it really interferes with the care. In that sometimes you're actually focusing resources on capturing the data and not focusing resources on a patient in the exam room. But again, it's a two-edged sword, but it is, I think, overall moving us in the right direction. And overall, these measures are starting to come together, and with meaningful use, and as people get more electronic, it's going to become less painful.
So for those of you who aren't familiar with some of this, so hospitals and providers are rewarded by Medicare and certain payers for doing certain things or having certain outcomes. And as Dr. Hoffman mentioned, there's a process measure and then there's an outcome measure. So the simplest example would be if you show up in the emergency department with chest pain, did we give you an aspirin? That would be a process measure. If we did that, then we would sort of, so to speak, check that box or know that we want to capture that. And the outcome measure would be if we check back with you, so you had a heart attack, you were in the hospital, you left. If we check back with you in 30 days, how are you doing? Are you still alive? Do you have to be readmitted to the hospital? So that's kind of the distinction between a process and an outcome. And the alphabet soup around it is the PQRS, the MU, meaningful use. As it relates to medical home, what I believe about it is I think those are all good things, and they came out on their own, and they are connected to medical home. Unfortunately, they weren't linked to medical home. So they're providing financial incentives, which our physicians and other providers are already receiving, which doesn't provide them an additional incentive to really participate in medical home, because those have already kind of gotten out of the barn. So, you know, ultimately all these quality measures are interrelated, and many of them kind of lead you to the common endpoint. It's just a matter of linking them all together and rolling them up to reward an entire, you know, outcome or episode of care for a patient or patient population.
Thank you. And I think we know meaningful use, a lot of meaningful use is based on the patient-centered medical home model. So it should be a crosswalk, but it sounds like we're moving it. I'll move to my next question, but please, if you have a question, just move to the mic. We're gonna have it open for your questions. We have a mic in the middle, but we'll continue with the questions until we see someone. Well, let's talk about the ACO, Accountable Care Organizations. Let's kind of transition, talk about the relationship of the patient-centered medical home to the ACO, but how is the ACO model really changing the landscape of healthcare? And can you also say how will it affect practices, maybe the smaller practices, as we move forward?
You want to start? And actually, there's a session after this one in which one of my colleagues, Kristen Greifer, will be on the panel talking about accountable care organizations. She'll give a lot more information about that. But basically, an ACO or accountable care organization is set up by Medicare as part of the Medicare Shared Savings Plan to incentivize systems to, as I said earlier, bend the cost curve for Medicare beneficiaries over large populations. So one of the starting points is you have to have at least 5,000 Medicare beneficiaries to be part of an ACO. WellStar has an ACO that has about 38,000 to 40,000 Medicare beneficiaries. And what we do is what's called population health management or population management. So as was talked about earlier, really looking at entire populations. And Dr. Greifer will go into more detail around how we stratify patients, and it's somewhat of a pyramid, with the foundation being the otherwise healthy, the well, people with maybe one or two conditions that are otherwise well controlled, you know, taking their statins and things like that. And then in the middle, a little higher up would be those folks who were more concerned about their condition, and they have the propensity to become what we call the sickest of the sick, or that top 5%. And that's really at the top of the pyramid, those sickest patients who are the highest utilizers of care. They make the most visits to the hospital, to the emergency department, et cetera. And they often have social needs that aren't always addressed through a traditional, you know, healthcare system. So that's kind of my version. I'll let you guys talk more about an ACO. But the question about, you know, smaller hospitals and practices, how they might be affected, if ACOs ultimately become what are called narrow networks, that I think one of the speakers talked about, where you have preferred providers and really care is only provided with a limited set of physicians and other facilities, that will put pressure on some of the smaller entities to become part of an ACO or something very similar, because they wouldn't want to be carved out of that network of care they want to participate. So we do see interest, for example, from the health system amongst what we call skilled nursing facilities or post-acute care providers to kind of involve themselves in the ACO to, again, be part of that continuum of care.
Now, let me ask you, just put this in the mix. Does a smaller practice have to be a patient-centered medical home to be part of an ACO?
You do not have to be a medical home to be part of an ACO, but a medical home is a way of delivering the benefits associated with ACOs.
I think it would be difficult if we weren't. And I think one of the hardest things for us physicians, I've been doing this now for 30 years, so I think having to be held accountable to somebody else has been a hard thing. I mean, I think one of the things you guys have to do a lot is manage doctors and hold them accountable to make sure that they're practicing high quality and having good outcomes. The smaller practices tend to be physicians that didn't want to be employed or didn't want to be part of a large health system. So it's a little bit of a leap of faith for them and a transition for them to be able to function in that kind of a system. And where the rubber really meets the road, the ACO has to have physician managers, such as you guys, to manage the physicians that are in your ACO, to make continue to improve and manage costs as well as quality.
Yeah, I think the skill set that we learned early on for the ACO is very much like PCMH. In fact, I don't really find a lot of differences. It's almost identical.
I think that sort of answer the question. I think that it actually is a good thing for the small. It can be a good thing for the small practices. I think it's as healthcare gets more and more complex, and that's sort of a recurring message. As healthcare has become more complex, it's very difficult to just manage within your silos, and that includes, the small practices. There needs to be an integration with the larger system, and how attached you are with that larger system, really gets into the discussion about clinical integration and whether they have to be employed or not employed and those kinds of things. But the point is that when you talk about electronic integration, when you talk about the electronics just an enabler. I need all this process wrapped around all this electronic support, all this electronic infrastructure to actually impact or affect the care of the patient. And so, for example, sort of alluded to earlier, you've got this pyramid of patients, of perhaps the high-risk patients. What happens to those high-risk patients if it's just like give that list to a small practice and say, go at it and make sure that you take the best care of them you can? They're running as fast as they can. They don't have the capacity to do that. But to support them, perhaps with care coordinators or health coaches, or that type of infrastructure that they can't otherwise afford, but is better from a population perspective for that group of patients. Those are the kind of things that you can't do if you're an independent small practice. But if you're willing to collaborate and be in a system, and in my mind, we're a clinically integrated network. We have a contract that now makes us an ACO because we're accountable for cost and quality on this population of patients. But so in my mind, the discussion is really around clinical integration. I think it's no longer a solo sport, and we need to be in a larger team, and that team extends beyond. First of all, that team includes everyone in our office, which it didn't used to before, but now it includes those outside of our office as well.
We've been through a number of cycles with the healthcare system. Some people would say, well, we've been this way before with HMOs, etc. Is it going to be different this time? Well, I guess you need a crystal ball to answer that, but don't answer that. What do you think would be different this time? How is it different this time with PCMH? Can you guys comment?
I think my crystal ball is very cloudy. When in the 80s, I was still active Air Force and hadn't retired yet at that point. So I didn't get to experience it in the private sector really, although the military system in itself, like an HMO. But I think definitely the HMO was the physician was protecting the dollars of the insurance company. And now I think it's different because we're protecting the patient. We're acting on the behalf of the patient. And I think that's what the difference is. So I don't think we're repeating ourselves. But again, I didn't experience it personally. So.
Well, I was a medical director in several HMOs, so we lived through that. And I think this is going to be successful. Unlike what made me a real believer in the PCMH model was that when we tried to do this in the 80s and 90s with capitation, and even full risk capitation with large physician groups, because I thought we already had this kind of care. As I mentioned, I thought back in 2007 when I first started hearing about the PCMH, I kept thinking, aren't we already paying for this under our capitated model? This is not, the PCMH is not a gatekeeper. And that was what kind of killed a lot of the HMOs, especially in public opinion. Having the primary care physician seen as a gatekeeper, this is not what a PCMH is. The other thing that we didn't have in the 80s and 90s is the tools by which to manage a population. There's no such thing as electronic medical records. We may have had claims data that was old, as I say, the physicians didn't have the tools. The other thing, the insurance companies tried to do all the disease management. What's different about the PCMH is the disease management, care coordination, coaching is in the physician's practice where it should be. Rather than me as a practicing doc getting a letter from Aetna, a letter from Blue Cross, a letter from United, a letter from Cigna, telling about my 10 patients based on data that's 90 or 120 days old, I wasn't very happy about that. I didn't like it. So what's now different is that all of those functions are in my practice. So the coaching, all that. So that, I think, is going to make this model a lot more successful than what we experienced before.
I think if this is going to be successful, it's either you make a choice that you're going to be the insurance company and the payer, like those of some in our market have done, or you find a good partnership between a payer who's willing to take on the insurance risk and a good provider group that's willing to take on the medical risk and own it and partner together and own it and share the expertise. I think what happened in the 90s or in the late 80s and 90s was that number one, you had relatively unsophisticated healthcare systems willing to take on risk in an uninformed way. So there are all kinds of problems with those contracts, but also those naive healthcare systems, including us, those naive healthcare systems thinking that we can just practice the same way we've always practiced and just be more careful, and somehow that's going to result in lower cost of care. I think we're much more informed now and realize that there's a dramatic infrastructure change that needs to happen, medical home being one major part of it.
Thank you. Are there any questions? We'd like to open it up for questions right now. If you have a question, please go ahead.
Can you share your view on NCQA accreditation certification for PCMH and what's your view on it?
You mean in terms of the measures? And
The quality
process?
measures, the process is it justifiable now that since it's not quite PCMH focused but more meaningful use focused, where it's going and your view on it, and do you have the infrastructures to support all the quality measures that are required as part of NCQA?
I would say meaningful use is just one small part of NCQA recognition. That's just, they've moved towards that because there's standards that address electronic medical records. They've melded them with meaningful use so that you're not having to do two different things. But there's many of the other standards are a lot different. They're about things like coordinated care, quality improvement, guidelines embedded in your medical record. Those are the things that have to be in place. NCQA is just one of several accredited bodies. There's Bridges to Excellence is another, AAAHC, I forgot what those acronym stands for. A lot of the Walgreens clinics are going through that accreditation, ambulatory accreditation. So insurance companies, if they're going to change their payment model, which is usually a care management fee, the PMPM that Dr. Youngblood talked about, and as well as an enhanced fee schedule, which is the other piece of that. And the third piece is sharing cost savings with the practice. If they're going to do that, almost all of them are requiring at least some level of NCQA, PCMH recognition. And in fact, WellCare is the first CMO, Medicaid CMO here in Georgia, that has started reimbursing at a higher level if you are PCMH recognized. And each level of recognition gets you higher reimbursement. Level 3 gets more than level 1. So things are moving in that direction. So it's kind of that good housekeeping seal of approval thing that you kind of have to do.
And we have a lot of the resources in place for measuring quality, measuring outcomes. I think what we found the most challenging for NCQA certification around medical home is process change, getting people to do things differently and getting them to work more as a team. The traditional model is, okay, you start seeing patients at 7 a.m., let's get started, you just go, and from there you're on the treadmill and you're running all day. Medical home requires that we do patient huddles in the morning, when everyone get together and talk about the plan for the day, talk about those particular patients I mentioned. The other thing is it's really challenged us to look at how can we provide primary care, how can we do it better? And one of the things that we're moving toward is integrating behavioral health into our primary care settings so that patients with those needs can get that care right there in that same location where they're used to seeing their primary care physician, where they feel like they're part of that family. and it's a more comfortable setting, so we're going to bring that into the primary care setting. But you know, as Wayne had said, there's a lot more to it than just meaningful use, and it's actually a pretty laborious, time-intensive process that requires a lot of tracking and data and analytics and capturing of that information.
I think to answer your question, at least from my perspective, there are practices that are NCQA certified that really don't do high-quality population health management, and there's the converse, that people who aren't NCQA certified do a very good job at that. But it is a standard, and if somebody's going to start writing checks, they want a standard, and so it's just kind of a necessary evil. And I understand there's discussions at CMS where they're going to come out with their own sort of criteria that will embrace a lot of what's in the NCQA certification, but still, you know, try to get more at the meat of what's real population. Your question's a good question.
We have about 5 minutes left, so.
If in fact there's a shortage of primary care, family practice doctors, and they're I think obviously the lowest compensated of all doctors, how can we encourage people in medical school to become family practice doctors, become primary care doctors? How can we increase the pool of primary care physicians?
Just speaking as the academic medical center here. So first of all, we have a whole initiative now focused on primary care. Your point's well taken. This is just purely my take, nothing official. We need good role models. We need the students and the residents to see a practice that they want to be a part of. And honestly, I think at least our medical home is one of those practices. The compensation model needs to be reasonable, and the lifestyle needs to be reasonable, and then that needs to be valued by the organizations that train learners. And I think it's because of what's happening across the country with this, I think that's becoming more and more valued, but it wasn't historical. And so, you know, it takes a lot of that, but I will tell you that Emory, for one, and we're probably the worst in the state when it comes to creating primary care docs, we have this huge focus now on how do we increase the number of people choosing primary care out of our system.
I think the other piece of that too is we also have to, one of the things that we found both in research and anecdotally with our patient-centered medical home university is that physicians and their staff love this model. Primary care docs that are practicing at PCMH are much higher levels of satisfaction. So in addition to the payment model reform, I think once we get physicians or students and residents into this kind of a setting, they'll say, gosh, this is kind of fun. You know, this is what I went to medical school for. So I think that will help.
Let's try to get a few questions.
Here's my question.
Oh, I'm sorry. Yeah, go ahead.
I come from a finance perspective. I also have a child with medical issues. And I can communicate with his doctor and come to a solution via email pretty much most of the time. But then he only gets paid when we have an office visit. So, Peter, I know you were talking about payment, reimbursement for medical services that are done via electronics, through technology. What do you propose to be a payment model? And the bottom line is the doctors and the medical professionals need to be paid for the services that they give through an electronic process.
If there's enough value in that interaction, we believe that they should be paid for it because it's a time saver, but there's still actual health care being delivered. So yes, we think that there should be payment methodologies related to electronic care. Who's going to pay for that, I think, you know, is the big question. I know that there are some models, some experimental models with payers to put that together. It may ultimately come down to, particularly with the change in the way our own coverage is provided, you know, with high deductible plans and health savings accounts, that cost or that expense goes to you as the patient, and that you pay for that as a convenience at a reasonable cost. And I think most people would be willing to pay for that. Again, as long as there's enough value in that interaction.
I would just say flash forward 3 to 5 years as more and more of our organizations start taking risk, and then having the insurance company make a rule that decides how we reimburse is going to be irrelevant, and it's going to be what creates value for the patient and what creates value for the system. And there are a lot of examples where fee-for-service just doesn't make sense, because to make a general rule that they're going to pay for A, B, C, D, it may not be something that an organization is willing to do. But as an individual organization who has full risk can then say, that's a high-value thing for me. I'm going to create infrastructure to support email communication because it's a lower-cost way for us to be able to deliver better care. And so I think it's going to be less convincing somebody to pay for it and more, give me overall risk, and then I'll decide what's valuable and what's not, or will decide what's valuable and what's not.
We're going to have to go ahead and end it. They're coming out with that long hook to pull us off the stage. But we certainly want to thank you all for involving conversation, valuable conversation. We hope you enjoyed it. Thank you all for coming. Let's give our panel